Good evening, ladies and gentlemen. The talk tonight is about management of a small group of patients, but one with a miserable future without our help. Injury and surgery can cause 3 nerve pathologies, leading to intractable pain. There are, of course, other causes of peripheral nerve pain, but they're for a discussion at another time. Physicians have struggled with these occasional results of injuries for hundreds of years, albeit under a variety of names. Many of the patients have had a nerve injury, but some are victims of normal healing, with the body laying down scar tissue in the normal way, which by chance traps a nerve in the vicinity. This is not a common endpoint of nerve injury, and I believe quoted N neuroma incidences between 0.5 and 40% are much higher than reality. Most injured nerves simply stop working. However, with more years, more patients, and more surgeons, the numbers build up in any unit, and this is why I became interested in this subject. Information is scattered throughout the literature of many medical specialities, and our own literature deals poorly with the subject. So we're all lacking in management skills, with some fear that we may make things worse if we do anything at all. These cases are also often something of an embarrassment to us when they complicate an otherwise good operation. But we need to move on from just ignoring or offloading these problems. I believe that they have 5 treatment options and 6 if we include doing nothing. Long-term use of oral or transcutaneous drugs can be effective, but they don't always work, and the side effects are sometimes as debilitating as the pain. They're also a life sentence to medical control. Local treatment is our contribution. First, transcutaneous neuromodulation. This is an electrical treatment similar to applying a TENS machine, which only takes 10 minutes and is usually painless. In this study, 48% of 72 of our patients benefited from this treatment. So if this 10-minute treatment keeps patients pain-free for longer than 1 day, many patients will prefer this to taking drugs or to surgery. However, it only works in half the cases. The equipment costs nearly £1,000, and we don't have enough machines to hand on to the patients without them buying them themselves. Local surgery is our main treatment and achieves pain-free or near pain-free status in 80 to 90% of cases. And if it works, the patient is no longer medically dependent. However, it involves 1, sometimes 2, occasionally 3 operations, and it fails in 10 to 20% of cases. Spinal root stimulation is a procedure carried out by some, but not all, pain clinics. The stimulator is inserted where the nerve roots exit the vertebrae, and the wires are tunneled to a subcutaneous battery at a distance. It can be an excellent treatment, and it's our next stop for our failures. However, it involves an operation, sometimes more than one. Infection requiring removal can be a problem, and placing the stimulator at exactly the correct spot is another. Unwanted motor stimulations can occur, and neck movements can also affect what it does. And of course, the patient is dependent forever on a pain clinic for battery changes. Psychologists can teach these patients mental tricks to distract them from the constant pain. I'm not sure how effective this is, as we use it very little. Lastly, radio manipulation of the CNS pain center. Exactly how this works is not known. This is an end-stage option for the desperate patient, and while most of my patients will accept local surgery even more than once, many will not go even so far as a spinal root stimulator, far less what they describe as interfering with their brain. I use this diagram drawn roughly in the notes to take each patient through the treatment options, and then I direct them as they feel they want to go. If they stay with us after a trial of 2 to 3 sessions of neuromodulation, if this is unsuccessful, we moved to local anesthetic injections in the outpatient clinic to identify the nerves involved. While we don't know what actually causes the pain, these simple mechanical pictures are useful to us and I think to the patients. But the reality is more complicated. In this study, we showed high levels of nerve growth factor at sites of nerve injury and pain, which disappear when the nerves are relocated into bone or muscle. It's likely that this and possibly other factors are simply markers, not the actual irritant. Professor Anand has also shown that nerve growth factor is not being produced by the injured nerve, but by the damaged tissues around it. Pain is usually a complex of symptoms for which we have no common language, making for difficulties of communication. Hence, the complaints are difficult to understand from the patients and difficult to talk about among ourselves. However, the complaints, I think, can be grouped broadly under these 4 headings, with the degree to which each is present varying. Spontaneous pain at rest is arguably the most unpleasant. There's usually a continuous aching, often with some more severe spikes of pain, which occur with very variable frequency, but usually several to many times a day, and sometimes accompanied in severe cases by reflex motor jerking of the whole limb. Isolating the painful limb from contact with the outside world can avoid the other 3 pains, but there's no way to be rid of the spontaneous pain without medical help. And those of you who've had severe toothache will recognize this pain. These patients have often had this limb toothache continuously for months or years before they come to us, which is perhaps enough to make anyone a little strange psychologically. Different aspects of the pain seem to fit with different models of pathogenesis. I think it's important to have a clear idea of the goal of treatment in these patients. Our main concern normally when dealing with sensory nerves is distal sensation. Here, alleviation of pain is the main concern, and sometimes distal sensation has to be sacrificed. However, this is already usually poor or non-existent, so losing it is usually no great concern to the patient. I think we should remember here also that nerve reconnection, in adults at least, rarely achieves normal sensation. Nevertheless, reconnection of divided nerves is the best prophylaxis against neuromas, and it can sometimes be an effective pain treatment by capping a painful nerve end. A caveat, however, here, if the proximal nerve end is already painful, some reconnections will propagate the pain distally as the nerve recovers, and others will tether at the operation site in scar, converting a painful end neuroma to a painful scar neuritis. And both of these problems may be best treated by cutting the repair and relocating the proximal nerve end. If there isn't a distal nerve end, transferring a flap or a toe to bring in a distal nerve is ingenious, but it can sometimes run into these same 2 problems. When nerve reconnection is possible, our current treatment of end neuromas, based on an experience of nearly 400 painful nerves, is to relocate the nerve ends to a more proximal and deeper site, where there'll be a less significant source of pressure and movement pain. And almost invariably, this also reduces both the spontaneous pains and the skin hypersensitivity. As you can see here, this is not new. Although the literature is small, it has identified the good and bad relocation sites. Nerves in continuity which become painful include those with a nerve injury which form a neuroma in continuity, which is then tethered in scar to its surrounds, and those which were never injured but simply become tethered in scar tissue. Other than the nerve swelling, the gross appearance of the 2 is very similar. They both create the same pain problems as each other and also as an end neuroma. The treatments in the literature have mostly involved neurolysis or neurolysis then wrapping the nerve in something. Most papers present very small numbers of cases with only about 50% success and no advice on what to do with the failures. These painful nerves in continuity split broadly into two groups in respect of how we now treat them. If you repaired one of the nerves in the upper left box and recovery was poor, you'd probably not be too upset because their distal function is not vital. So with this fact in mind, and because most of these injured nerves have poor distal sensation anyway, and because wrapping nerves has less certain results in our hands than relocating in neuromas, we now cut any of these nerves if in continuity and painful, and relocate them as we do in neuroma. If you look more critically at the vital nerves on the lower right, the digital nerves to the vital pinch areas are usually injured and tethered in the distal palm, and we've had poor results treating these with neurolysis and wrapping. As they almost always have very poor distal sensation and have already been bypassed functionally, we now also divide and relocate these. So this leaves only the median and ulnar nerves as truly vital. Although distal function is also usually poor, it can't be replaced, so it has to be kept. And so we wrap these nerves. We find it useful to split the distal upper limb into three zones. This slide shows the relocation site we use for each zone. We need to record the degree of pain before and after treatment, and we found it easier in busy clinics to record the degree of pain like this, not by pain charts, which can involve some explanation for the patient. In reassessing relocations, one has to examine their effect at both the primary and the relocation site. Here in a made-up chart, preoperative pain levels at the primary site are marked on the left in red, and the post-operative pain levels at both sites are shown in blue. This shows a zone 1N neuroma at the tip of the index finger being shortened and buried at the base of the proximal phalanx. When the nerve problem is nearer the base of the finger, we take the nerve back into the palm through the hand and into the lateral surface of the metacarpal. Some nerves buried at the base of the finger continue to hurt on full finger extension, so we have to move them at a second operation into the metacarpal. Some nerves in the metacarpal, in a few patients, get pain every time they bump the back of the hand. These are often workmen putting their hands into narrow spaces. Because the dorsum of the hand has very little padding, that is the reason for this, I think. So we move these to the pronator quadratus. This is our 2004 analysis of 104 zone 1 relocations. The next few slides are very busy, but I'd like you just to get an overall impression of where on a scale of no pain to severe pain, things move from the red preoperative measurements on the left to the two blue post-op measurements. Before surgery, the red primary site pain numbers contain a lot of moderate and severe pains in most modalities for most patients. After surgery, 2 had mild pressure pain at the original site, which usually means that something has been missed. The pain problems at the relocation site are mostly pressure pain at the metacarpal relocation site, which usually resolves if the patient agrees to a further operation to move the neuroma to the pronator quadratus. Nerve ends in the pronator may have pain on extremes of movement of the wrist, and we presume that these movements tighten the muscle onto the nerve end. In reality, we don't use these extremes of movement very much, and the patients learn to avoid them. Looking at the same chart, but highlighting only the completely pain-free post-operative cases, 80 to 90% of pain in most modalities has gone completely. In zone 2, we bury the nerves in the pronator quadratus muscle at the wrist, and this is our 2006 review of 46 zone 2 nerves relocated to the pronator. Again, preoperatively in red, a lot of severe and moderate pains. The first blue column shows good but not 100% pain relief at the primary site, so something was probably missed. And on the far right, most but not all pain is in the mild and none columns at the relocation site. As mentioned above, some patients have mild or moderate pain at this relocation site on extremes of movement, and they'll learn to avoid this. They may have pain on pressure if they hit the volar aspect of the wrist, but this site is hit much less often in daily life than when the nerve was in the hand, and this doesn't pick up on this means of assessing the neuroma's pain. Looking again only at the 100% pain-free results, around 80 to 90% of the modalities are pain-free. The radial border of the wrist is the commonest site of trouble in zone 3, the forearm. It's a watershed of 4 nerves, which all need to be thought of whenever this site is injured and becomes painful. The superficial radial nerve and the lateral cutaneous nerve of the forearm are always present and have been shown to interconnect at the wrist. So I routinely now relocate both of them at the same time to the brachioradialis. The branch of the posterior cutaneous nerve of the forearm nearest to the brachioradialis very occasionally comes down as far as the radial wrist and can be involved and may have to be relocated into the brachioradialis. Occasionally, the dorsal branch of the ulnar nerve sends a branch across the back of the wrist. If present, this nerve is taken back to its origin and buried in the pronator. So in cases with radial wrist nerve pain, local anesthetic studies are essential to identify which nerves are present. If the 2 main nerves only are relocated and the others are present but missed, the pain may not go away, as we can't see which nerve or nerves are the actual problem. The posterior intraosseous nerve also needs to be considered in these cases. Although its only function at the wrist level is wrist joint sensation, it can invade an empty superficial radial nerve territory after division of this nerve at the wrist to cause severe secondary hypersensitivity, which usually manifests 6 months later. So we now routinely divide this nerve also, as when we do wrist denervations, when we're relocating for radial wrist pain. If the lateral cutaneous nerve of the forearm is the problem alone, we put this into the brachialis muscle above the elbow. These are the zone 3 brachioradialis relocation results, with again, broadly speaking, 80 to 90% reduction of all pains. Coming back to the incontinuity vital nerves at the wrist, we wrap these in local fascial flaps. This is simpler than using free flaps, and it localizes the surgery to the injured limb. This is a Becker fasciocutaneous flap based on the dorsal branches of the ulnar artery, which I use specifically for typical neuromas in continuity of the median nerve, as it turns through 90 degrees to lie directly over these, and it's just wide enough to cover the neuroma. The final step is to remove the skin from the distal end of the flap, turn the fascia back under the neuroma and sew it to itself, so isolating the neuroma from the movements of the long flexor tendons. Scarring neuritis and some neuromas in continuity create a longer length of nerve damage, and for wrapping these, the whole of the fascia of the flexor aspect of the forearm back to the cubital fossa can be raised on the small fascial feeding vessels coming off the anterior side of either the ulnar or the radial artery. And which artery is used depends on the scarring already on the forearm. We lift the flap with as little fat as possible to reduce its bulk and make skin closure at the wrist easier. Roberto Adani actually prefers to include fat for padding. With this technique, and this one has more fat on it, it's possible to create a long fascial flap which turns through an easy angle to lie along the length of a damaged median nerve through the carpal tunnel and beyond. We've done about 30 to 35 of these fascial flaps now. In some cases, the wrap alone was enough, but a number of them seem to tether to either the wrist or the radial flexor tendons, radial finger flexor tendons, giving pain on movement of the fingers, of the wrist and or the fingers. and pain relief can be improved by fusing the wrist and sometimes removing the superficial flexors of the index and middle fingers. And this is done at a second operation, with again about 80 to 90% of the pain very much improved or completely cured. Though this is a much smaller series than the relocations, even if more than other nerve wrap papers in the literature. The main problem we have with these patients is that having made them more comfortable, some of them go back to heavy manual work, probably too early, and set the pain going again. These relocation and wrap operations are painful and need considerable pain management in the immediate post-operative period. If the first operation isn't working at 2 to 3 months after surgery, it's too easy to blame the patient and stop. So first, we think again locally, have we left something behind, or can we do something else? If stuck with local treatment, our next move is referral for a spinal root stimulator. This can be stunningly successful, but also has its failures and requires long-term follow-up. So it's not the easy escape from medical hands of a successful local operation. So I think there is mileage in this local surgical approach before moving proximally up the nervous system, as it can free the patient of both pain and medical involvement. I'm aware that the other ideas as to how to deal with this problem. At present, there's a fairly prolific output of papers in the American literature from Harvard suggesting the way forward is to reconnect the divided nerve to a nerve or muscle distally to quieten the brain down. This may be the way forward, as it's trying to reclaim distal function as well as get rid of pain. But our experience has been that the distal sensation will never be normal, can be troublesome, and reconnection may swap the current problem for another pain problem. So since writing these results up a decade or more ago, we've gone on doing these relocations and wraps with much the same results. And before finishing, I'd like to consider briefly scar tethering of nerves, which is the basis of our latest work, and also speculate on why we all have a failure rate, whatever we do with these patients. What are we missing? Adhesions are not something abnormal in a few patients, but part of normal healing. However, they cause much of our problems after hand injury and surgery. With respect to nerves and nerve tethering, severe pain in the scarred brachial plexus was first reported following irradiation, and fibrosis causing nerve compression is believed to play a central role. Chronic nerve pain associated with scarring around the median nerve at the wrist was first described by Hunter in 1991, and the name given implied tethering by scar. More recently, we looked at 134 of our nerve pain operations and identified 22 patients with severe nerve pain in smaller but named peripheral nerves following injury and or surgery in which the nerves themselves were definitely uninjured but were tethered by scar. There were about the same number again who almost certainly fall into this group, but we couldn't prove the nerves were definitely uninjured, so we excluded them from the paper. Nerve pain is listed without explanation as a complication of many hand operations, with a lack of adequate treatment also being identified. Given the universality of scar formation at all surgical sites, I think it's not unreasonable to consider that scar formation rather than surgical misadventure, by which I mean our cutting peripheral nerves, may explain at least some of these pain problems. Although whether scar causes the problem of pain by preventing nerve gliding, compressing the nerves, or by a chemical process is unknown. I'd like to consider briefly a few post-operative pain problems I see not infrequently both in my own practice and sent in from elsewhere. And you may recognize some of these from your own practices, where scar tethering may explain the patient's unhappiness with what should have been a successful management. Patients who experience a dorsal crush injury of the hand will commonly tether their extensor tendons, And we diagnose this by forced passive flexion of the fingers to show reduced finger flexion with discomfort on the dorsum of the fingers and hand. If, when you do this test, the patient hits the roof and pulls their hand away, I'd suggest gently nail testing the back of the hand to identify if there is tethering also of the dorsal hand nerves. When there is, these cases are too painful to respond to therapy and ultrasound, and surgical tenolysis without previously relocating the nerves will fail, as the tethered nerves remain too painful to allow the therapist to mobilize the freed up tendons. By the time radiography eventually identifies that there's no scaphoid fracture in these cases managed by repeated x-rays and casts, the multiple immobilizations have allowed fibrin edema to tether the radial wrist nerves, and the ongoing pain is not skeletal pain, but scar tethering of the nerves and nerve pain. For me, this is a not uncommon, albeit usually very delayed clinical referral, and it's also common in my medical legal practice. Most de Quervain's releases and other surgeries in this area that run into nerve trouble are arguably not cut nerves, but tethered nerves. And after a carpal tunnel release or trapezotomy through the anterior approach, the palmocutaneous branch of the median nerve can also sometimes become scar tethered. Superficial radial nerve releases at Wartenberg's point are also not immune to this same problem. Earlier, I explained our philosophy of nerve division and proximal relocation for these non-vital nerves, as neurolysis alone and neurolysis and wrapping the nerves has had such poor results in our hands. But this we can't do with the median nerve, whether scar tethered after carpal tunnel decompression or after open wrist injury. The compressed ulnar nerve has potentially 3 scar tethering problems in my practice. A few months after simple dorsal release, the nerve may tether, causing pain behind the elbow, which is worsened by elbow flexion. After anterior transposition, the nerve is likely to tether again, as the patient won't have changed their healing pattern. And this will then cause pain on full extension of the elbow, but the patient can flex the elbow to eat and to carry out toilet necessities. I warn them of this and that they can avoid the pain by avoiding full elbow extension and carrying with the other hand or across the forearm with the elbow flexed. A few of them will develop severe intractable pain, and until recently we referred these patients for spinal root stimulator insertion. Recently we've started carrying out neurolysis in these patients and then wrapping the nerves in the same anterior forearm fascia as the nerves at the wrist, but based proximally on a small branch of the radial artery which comes to the surface very proximally and just beyond the elbow cubital fossa. However, we haven't got far enough with this technique to say whether the pain relief is as good as the nerve wraps at the wrist. Before finishing, I'd like to consider possible reasons why local surgery for nerve pain, whatever one does, may fail. Technical failures for what are pretty simple surgical procedures should be few. Using relocation sites recognized in the literature as unsatisfactory and not adequately burying nerve ends in muscle or bone, so they stay there once the patient mobilizes the limb, are 2 avoidable errors. However, I think more likely are failures of knowledge of the peripheral nervous system. It's not common knowledge that the radial border of the wrist is a watershed of 4 nerves, any of or all of which may be present, so any or all of which may be damaged. So simply doing something surgical to the superficial radial nerve without first investigating for the presence of the other nerves by local anesthetic blocking may fail, as any nerve present needs to be relocated, and very occasionally this means relocating 4 nerves. The black arrowed branch of the dorsal branch of the ulnar nerve may be involved in this. And this branch also explains the possibility of neurogenic pain after wrist arthroscopy. You can also see from this particular dissection that you can't be 100% sure without local anesthetic studies that the radial side of the dorsum of the hand is superficial radial nerve territory. Bass and Jim Kleinert showed that the innervation of the fingers from the dorsum of the hand doesn't always stop at the PIP joint, as we're taught. Obviously, finger stump pain in proximal finger amputations may come from the dorsal hand nerves, but this may also be the case for some distal amputations, particularly if closed by turnover of the dorsal skin, and particularly in the little and index fingers and the thumb. The peripheral nervous system is much more of a network than we're commonly taught, and this can give rise to confusion in identifying the source of a nerve pain, particularly in the palm of the hand, as there are 4 median to ulnar interlinks, 2 of them actually in the palm. Looking at the percentage of crossovers reported in these original papers, which is shown in red here, these are not rarities but quite common. Several anatomical studies have shown that these 2 nerves reconnect with each other distally. So, as mentioned earlier, after nerve disasters at the radial wrist site, I now routinely find the lateral cutaneous nerve branches in the fat on the flexor side of the brachioradialis tendon distal to the muscle, take them back and bury them in the brachioradialis as well as the superficial radial nerve. Bass and Kleinert also showed small connecting nerves in the fingers between the nerves of the dorsum of the hand and the digital nerves. And I've seen these personally on a number of occasions. So, faced with neurogenic pain anywhere in the finger, a local anesthetic block dorsally just proximal to the MCP of the involved finger is always necessary to warn if branches of the dorsal hand nerves are going to be involved and need to be treated. Oddities which don't fit with our preconceived ideas crop up in any field of surgery, and they certainly occur in these cases. These are a few with no conventional explanation. The terminal branch of the posterior interosseous nerve carries sensory fibers of the wrist joint only. It has no skin territory. I mentioned earlier that if the superficial radial nerve is decommissioned, the posterior interosseous nerve may somehow innervate the empty skin territory and cause intense hypersensitivity. The how is not known. However, it's well recognized from joint denervation surgery that part of the sensory innervation of the CMC joint of the thumb comes through the motor branches of the median and the ulnar nerve. A Dr. Froment in 1846 recorded innervation of the first dorsal interosseous muscle in some individuals, not from the motor branch of the ulnar nerve, but from this terminal branch of the posterior interosseous nerve. So this may be the explanation. Wrist denervation includes stripping the soft tissues from around the radial artery at the wrist to remove branches of the lateral cutaneous nerve of the forearm, which go to the wrist joint through the arterial adventitia of the radial artery. If one strips all 3 conventional innervations from a finger, the patient still has PIP joint proprioception and very occasionally still fingertip pain. And this may also be transmitting through the arterial adventitia because all of the known nerve system has been removed. This case would suggest it is true. This man had his thumb completely denervated by me for amputation stump pain distally, but he retained a small circle of skin hypersensitivity just where the radial artery dives into the first web muscles until I stripped the adventitia of the radial artery at the wrist and the hypersensitivity disappeared. In a different scenario, post-carpal tunnel surgery scar pain caused by the palmocutaneous branch of the ulnar nerve is very rare. It can be differentiated from pain coming from the palmocutaneous branch of the median nerve by local anesthetic studies. I've operated twice for this as the scar pain was so severe. In one, I found a very small nerve, as in the textbooks, and buried it in the pronator quadratus, which relieved the pain. In the other, I couldn't find this little palmar-cutaneous branch of the ulnar nerve, so I stripped the adventitia of the ulnar artery for about 3 centimeters proximal to the wrist, and the pain disappeared. With fingertip neurogenic pain, if local anesthetic studies indicate one digital nerve only, we only relocate this nerve to achieve a pain-free finger, but still with some distal sensation from the other nerve. In a few cases, we observed that the pain which had gone away then returned 6 months later, and local anesthetic identified the other digital nerve as now being involved. And we've also seen this phenomenon occurring in complex forearm cases with severe hypersensitivity. Local anesthetic identified the feeding named cutaneous nerve or nerves. Relocation of these was followed by a reduction or even disappearance of the hypersensitivity, only for it to recur after a few weeks or months. Repeating this process for further nerves and getting progressively further away from the area of injury, the result would be the same each time until all or nearly all of the named cutaneous nerves of the forearm had been relocated, but still the hypersensitivity remained. And this warning from 1949 rings loud and clear. I've already mentioned nerve linkages in the upper limb that we know about. The cases I've just described suggest that the peripheral nervous system may be even more of a network than these. Those among you who are plastic surgeons will be aware of Professor Taylor from Melbourne's work showing that the skin of the body is split into territories supplied by specific feeding arteries, but with each skin territory linked to adjacent territories by what he called choke vessels, with these choke vessels capable of opening up to allow flow through from adjacent territories should the main artery of a skin territory be cut off. Many of these patients with nerve pain who don't respond to our simple surgical activities with instant success are behaving as if a similar network with shunt nerves occurs in the peripheral nerve system. However, these studies by Professor Morrison in Melbourne and Professor Anand in London suggest a chemical phenomenon as an alternative, such that if one nerve has been relocated, a chemical might then stimulate the next nearest nerve. I realize that the last bit of this talk has been about sometimes only single cases, at best small numbers of cases, and these can be misleading. Unfortunately, overall, this is a small population of patients, and most individual surgeons are unlikely to see enough of these cases to accumulate sufficient numbers of the rarities to make science out of them. I think these unusual cases need to be discussed, and I'm grateful to the Derby surgeons for this opportunity to talk about them. Perhaps among them is the explanation for our failures, and they may point a way forward to improving our success rate. I thank you for your attention